Okay. Good day, everyone. Thank you so much for joining us for the GREX Kidney Day webinar. Today's title is Global Perspective on Wellness Interventions in CKD. And I'm so excited to be a part of this. I'm so excited that we're doing it. I'm Nancy Verdin. I'm a patient partner. I'm a retired occupational therapist, and I'm a PACER researcher. I'd like to thank you all for joining us. I think we've got some wonderful discussion points and some great research being presented to us. And part of my great joy is that the whole idea behind GREX is to bring wellness and recovery to patients living with CKD and dialysis. I was a crash start on dialysis in 1988 at the age of 28. And it was glaringly apparent to me at that time that there was no rehabilitation of any kind for any patient on CKD. And to say I was disappointed was an understatement. It was actually something that was mentioned in the Kidney Foundation of Canada book I was given, which was incredibly informative. But it was really disappointing to recognize that the message I got was that we didn't need it, or it wasn't useful, it wasn't present. And I was very grateful that my experience as an OT made my actual wellness and recovery much better, because I had some ideas as to what I could do for myself and how I could improve things. So when I was invited to join GREX, it was the first time that I'd actually see any organization that was truly looking at wellness and recovery for the kidney patient. So needless to say, I'm very delighted to be a part of that whole program. And it wasn't until I actually had a chance to talk to a kinesiologist involved in kidney care about how much my own level of fitness played in my wellness and recovery, and how it continued to support me. So at that time, I was walking to work and I lived in a third-story apartment. And that alone gave me a different level of fitness than many people had when they started dialysis. And my continuation of that actually facilitated my ongoing wellness and recovery. I think the other things that go with this is how important it is that we start bringing exercise and fitness and activity and movement to the chronic illness community, because at this point, we're still very much the medical model where we're going to give you some medication and we'll tell you what to eat and then you'll improve. And we know that that's not the whole picture. And that is the big difference when we're bringing exercise and physical activities. We're talking about the whole person. We're not just talking about their illness. We're really supporting them in recognizing that there is a better way, that we actually can create a better environment to have a healthier existence, more than existence, a healthier life where we can include the family and support network with them. So one of the interesting things that comes of this is that, can you have chronic illness and be healthy? Can you be, is that an oxymoron? Does that not make sense? And yet for me, because I continued with all my activities and went back to many of my sports, that I know that it did give me a better quality of life. And I really did feel very well. And I think that's important. And I did laugh because it was a concept.
I definitely agree.
It was one of those questions I think about while I was walking my 9 holes of golf after dialysis. So am I sick or am I well? The truth was I was actually well. And it's something that I really think that we need to pass on to other patients who probably don't even recognize that they can feel better than they can right at the moment. I think the other thing that goes with this is so much of it can and does involve the family. So it's not just the patient we're focused on. And I think that's equally important, that so often the focus is just the patient, when we recognize as a person that I want the people around me to equally be supported. And by including them in an exercise program, it generates conversation. We both feel better for doing it. And they actually are included in the idea of feeling better and feeling well. So I'd like to thank all our researchers for joining us and taking the time to share the studies that they're doing and the insights that they bring in creating a healthier environment. And this is the one direction that we're really creating, that we're changing that medical model, that it's not about fixing me, it's about all of me, and it's about all of the people that are doing this. And I'm so grateful to all of you for the work you're doing. I do believe that eventually we will look at healthcare as healthcare as opposed to being sick. And we'll also look at recovery and wellness as a part of coping and adjusting to a diagnosis of chronic disease. So thank you again for being a part of this. I'm very grateful for your joining us, and I'm looking forward to some very interesting information that's going to be shared through our event. So thank you very much.
Thank you, Nancy. So I will introduce our first speaker for today. Her name is Dr. Ria Arnold, and she is a NHMRC Early Career Fellow in the Department of Exercise Physiology, School of Health Sciences, University of New South Wales, Sydney. She is also an accredited exercise physiologist. Her research is focused on the role of exercise physiology as part of multidisciplinary care teams of dialysis and CKD patients. Her studies are working to identify pragmatic indicators for referral to exercise professionals and work toward equitable access to allied health services in this context.
Hi, everyone. Thanks so much for having me. I'll just share my screen. Okay, so today I want to share with you just an overview of what we think would be an ideal wellness intervention. And you can see at the top of our circle there, we have in pink, improved access to exercise service, which I think underpins and is really the linchpin of integrated healthcare in what we're trying to achieve here in Sydney. So in Australia, we have an excellent model of renal supportive care that coordinates and integrates nursing, social work and dietetic aspects of renal care, but the provision of physical activity and exercise remain notably absent. So we do have a health profession that could fill this gap, and we refer to ourselves as exercise physiologists, which you guys may know as kinesiologists. And our intervention would ideally embed the provision of exercise services within this renal services care model. And this would give us three key things. One, it would give us greater equitability in terms of access to exercise services, which in Australia are largely outpatient services or out-of-pocket costs and extra appointments outside of your usual care. Secondly, it would provide a greater opportunity for integrated care and reducing appointment burden for patients, as well as facilitating ease of access and holistic care for providers. And thirdly, it would provide us with a constant access, a constant presence, I should say, of exercise within the treatment model. And as Nancy so beautifully mentioned, having it as part of a holistic care and part of our ongoing treatment for healthcare over time, and create normality of the presence of exercise in this model. So in green is the foundation of the program in general. And basically it's founded in strength, balance and stepping. And this really links back to my background in peripheral neuropathy and the really severe adverse impact that I've seen that have on people's ability to balance and their confidence to interact with daily life. And this withdrawal from activities of daily living and exercise can actually go hand in hand and really accelerate that physical decline that we may see in some patients. So maintaining the ability to get up and down, in and out, step and balance to us is critical to maintaining functional independence. And I'd just like to share this picture with you. If I can't see all of my screen. And it speaks 1,000 words and probably more clearly defines my point than I can articulate. So the person in the picture here has kidney disease, peripheral neuropathy, peripheral arterial disease, diabetes, and congestive heart failure. And despite this quite complex health status, she is able to walk short distances and she has good stepping and good balance. And so it's thrilling to see that she can share time outdoors on uneven terrain with her great-grandson and really get the quality of life that we think all patients should have. So as I've mentioned, our program is particularly focused on maintaining functional independence, and that stepping, balance and strength is our foundation, but it can and should be tailored up and down as appropriate based on objective individualized assessments. And exercise physiologists routinely do this, and they would then also incorporate personal preferences into their prescription. And this would take into account logistical considerations and other factors that are likely to inform the type of exercise that the person is most likely to engage with and enjoy and embed for longer term behaviour change. And this can include options of intradialysis or interdialysis exercise, home-based or community-based programs, as well as group education sessions. These would, of course, need to be followed up by regular reassessments along with appropriate modifications to exercise programs. So in addition to that really formal aspect of an exercise program, part of what we would do as well would be to have our physical activity promotion, which we're always trying to do to help people identify strategies in their daily life where they can increase their informal physical activity and decrease sedentary time and really kind of achieve some of those targets for the recommended daily activity levels. And this overlaps with the next point in yellow, which is basically talking about our education strategies and sessions that can help empower individuals to understand their condition and understand the different aspects that they can use to overcome some symptoms and manage their health. The primary focus of our education modules would be to provide people with a toolkit that would allow them to take more control of health and symptoms and have some strategies around managing that. And the two yellow circles here are just examples of those. So fatigue, we know, is such a massive issue in chronic kidney disease. And there are different strategies that you can use, such as diarising and pacing, to help understand how we can manage those symptoms and really work physical activity and other treatments in and around those symptoms, as well as pain. We know that there are strategies that you can incorporate for that as well, with regard to knowing your pain, how we can use some cognitive behavioural strategies to react to our pain in different ways and really manage those going forward. These modules would also be, these are just examples, and we'd also really like to integrate multidisciplinary input such as dietetic programs and education sessions that are really related to things that participants themselves would really like to know more about. So getting their ideas of what some modules could be and developing that as time progresses. So finally, our program would really leverage education sessions and group exercise sessions to build networks that are connected via forums and social media. This component of our program would really seek to build networks and communities of people with shared experiences and provide them with a platform to communicate with each other, talk about things that are going well, things that are not going well, and support each other in that shared way. And so when you take it all together, basically our ideal wellness intervention really starts with enabling equitable access to exercise services and having some of these adjunct strategies that would really enhance the quality of a wellbeing intervention across the multidisciplinary team. And this is our blue sky vision. I'm really excited to hear what everyone else has to say, and thank you so much for having me.
Great, thank you so much, Ria. So now we'll open it up for discussion and questions. If you'd like to either post via the chat or just take yourself off of mute, and you know, we can have a verbal discussion as well if you'd like. So I'll open it up now. Actually, I could start it off. I have a question. You talked kind of briefly about kind of non-traditional exercise of physical activity, you know, incorporating kind of more housework, you know, gardening, things like that. One question I had is, and we're trying to do the same thing, how can you kind of measure improvements or increases in those type of kind of activities? Again, the non-traditional activities, again, it's very easy to kind of measure and track, you know, resistance exercises, but not so much kind of that, the daily, again, non-traditional exercise. So if you could comment on that.
Yeah, I totally agree. It's a really difficult thing to quantify, and we're really relying on subjective report from patients themselves and probably helping them identify what things they are capable of doing at the moment. And if that's changing over time, if that capability changes, But yeah, a very difficult thing to put a concrete value on. So I'd definitely be interested if you figure it out as well.
Yeah, it's Nancy. It is harder to put a number on it. And yet you'll often find them saying, oh, but I can garden longer, or I feel better, or that's where the qualitative gives you a different measure, because you can't put a number on that as easily. I'm delighted to see it. This is wonderful.
Yes.
Great. Do you want me to stop sharing my screen?
Sure. I think we have about another minute here for any questions that want to come through.
Yeah, thanks for that, Ria. Stephanie Thompson here in Canada. I really like the way you mentioned peripheral neuropathy. We don't often talk about that very much, and that's just such a huge barrier. And I feel like as soon as patients start talking about it, we do sort of back off a bit even, and we think, oh yes, you can't, you know, you might fall or something like that. So I think that's really fantastic. I also like the way you have almost like these separate, I don't know if this is how you were thinking of it, but like modules or streams for pain and fatigue. And just wondered if you sort of envisioned like how you might tailor or package, like, you know, were you thinking that like certain people could pick certain, maybe if you had fatigue, that there would be certain section education on like energy management, or if you were trying to tailor it to those things any more in terms of the educational parts?
Yeah, that's a great question. They're probably more a general information package. And yeah, it would be delivered to the renal group as a whole. So we have a similar model for our diabetes patients over here, where we have diabetes education sessions and different topics are covered. And I envisage something similar for our kidney disease patients. And within that, I think definitely with feedback from patients and things that they are really interested in, we could tailor it more specific, or have extra sessions with different types of strategies or different types of information that's more specific perhaps to CKD. So yeah, that would be what I would envisage. But I do think you're right. Probably a one size fits all wouldn't be ideal, but it's a starting point, and then we can yeah, kind of have more specific information.
They're also common, those symptoms, so you could just do a generic, like, yeah.
Yeah, and really embedding the strategies, you know, like for people to take ownership and have better health literacy and better kind of understanding of these things, so they can manage it and then hopefully integrate it into daily life. That's really what we're hoping for.
Great. So one last quick question here. How do you manage to motivate your patients to get involved in exercise programs and keep the adherence?
That's the $64 million question, but we start with little steps here. We always, we're coming sometimes from a foundation of a lifetime of not great engagement with exercise and physical activity. So we've found that the strategy is really just really small steps and getting that kind of balance and strength and confidence going. And when people get more confident with their ability to kind of walk there and get around and get up and down and in and out, things take on a little bit more momentum themselves. So that's really our first stepping point. And then I guess keeping participation is again linked back to that improved exercise services and having access to that, because you do need constant prompting and constant engagement with a professional, I think, to keep this going.
Great, thank you. If there's more questions for Ria, you can please post to the chat, but we'll now move to the next presenter.
Thank you.
Thank you, Ria.
Thank you, Dr. Arnold. Our next presenter is Dr. Paul Bennett. He is an associate professor in the School of Nursing and Midwifery at the University of South Australia in Adelaide, and is research director in medical clinical affairs at Satellite Healthcare in California. Paul is a board director of the Renal Society of Australasia and a foundation member of the International Society of Nephrology Kidney Health Professionals Working Group. Paul's research teams focus on strategies to improve the quality of life for people with chronic and end-stage kidney disease, using resistance and aerobic exercise, activation concepts, laughter therapy, home dialysis, e-learning, communication techniques, imagery, and workforce models. So Paul, if you want to share your screen for us and start your presentation.
Is that not sharing?
Yeah, we can see it.
Okay, cool. Welcome everyone. I'm going to talk about dialysis laughter therapy, which is a bit of a crackpot idea that people might think, what the hell is that? But we'll try and talk through it in the next 5 minutes. I'll take you a journey on the last 5 or 6 years that I've been through in relation to looking at whether laughter therapy can actually improve people's wellness and people's lives while they're on dialysis. And I'll go from the top left-hand side of the poster and sort of work through down and across in the poster. And surrounding the poster, you can see people's photos of people actually doing laughter therapy in hemodialysis, just to give you a picture of what it looks like. And most of these people are patients on hemodialysis from around the world, but you've also got, so the HDs mean people who are on hemodialysis, PCTs are patient care technicians, and MDs, medical directors, RNs, LTs are laughter therapists, and a CM is the centre manager. So we've got lots of people involved in laughter therapy. The journey started when I met a laughter yoga therapist who talked me through what laughter therapy was. Some of you will be aware of what it is, and pretty much we thought, well, this might work in dialysis because it's not just laughing, it's actually physical activity as well, which was my area of interest going back a while. So we first of all, we measured whether people, thought that this might be a good idea, and we looked at the happiness levels of people on dialysis and found that that people were particularly unhappy. Even though some dialysis clinics can be quite joyous and buoyant in social areas, we know that some of them also are quite bleak and people aren't very happy, and something like laughter. So in particular, people on dialysis have lower general life satisfaction. They feel like they've achieved less, and they have a lower relationship level. So we thought, let's do this group laughter therapy every day, every session for 4 weeks, and see how it goes. So we do this laughter therapy session, and what laughter therapy is we start off with a few warm-up activities, a few deep breathing exercises, and we sort of get a patient potentially in a meditative state as much as you can in a dialysis clinic. And then we start these laughter exercises, and these laughter exercises can be pretty much anything. So the exercises we usually do 3 times, and it might be a brushing the teeth exercise, and you laugh while you're brushing the teeth, or you wash your hair exercise, you have a shower in the dialysis clinic, which is my favorite. And basically it starts off as forced laughter. So people know, the brain knows that you're forcing this laughter. However, after a certain period of time, which doesn't take very long, it becomes infectious, natural laughter. The important thing is that your brain knows that it's been forced, but your body doesn't. So you're getting the same effects, the serotonin, the oxytocin supply that goes with laughter and happy emotions. So then we thought, well, let's try this a little bit more, and we'll try this over a longer period of time and see how feasible this is. So we did a feasibility study where we did laughter therapy once per week for 10 weeks. And we had fabulous Fridays or happy Fridays, and pretty much we did this over a week with laughter therapists coming in each shift of the dialysis a day. And we did interviews with nurses and with patients. And the yellow graph on the left-hand side, it's hard to see, but basically shows the laughter therapy perceptions of the patients. The light shows you, yes, they did enjoy it, and the darker people, no, not so much, and that's fine. And on the right-hand side, the yellow graph shows that the perceptions of the nurses, and yes, they thought it was safe, they thought it was good for patients. But the qualitative stuff was really good, that we found that most people really enjoyed it. And even if they didn't enjoy it, they liked other people enjoying it. But of course, we needed a proper randomised control trial if anyone was going to take any notice of laughter therapy. So we were able to do a cluster randomised control trial, cluster because we can't really have someone laughing in one chair and being randomised and not laughing in the next chair. So we randomised it by centre. So we had 10 centres, 5 doing laughter, 5 not doing laughter. We had 151 participants. And we found that, yes, there was an effect on some of the depressive symptoms that people had. So all that means was those people who had depressive symptoms, sometimes that was improved following these 10 weeks of laughter. And we also found that, we believe that really laughter therapy can sit alongside other programs. It's not the only thing, it's just one tool that potentially people can use for their wellness programs in dialysis. There are challenges. It's not easy. It sounds easy, but if you're a person and you're a laughter therapist and you come into a dialysis unit and you just start laughing and try to get people laughing, then people will send you away and get the security guards and take you out of the dialysis clinic. So it does take a certain time. So we get the laughter therapists in a couple of weeks beforehand. They sit down with the patients, explain what they're going to do. We have translators because laughter is certainly able to go across language, and we don't really need to be able to speak English or Spanish or Chinese to be able to laugh together. So laughter therapists come in early, they develop relationships, they get to know patients. We have a couple of centre laughter champions, and that's not that hard to get. Sometimes it's hard to get people to do extra work in dialysis clinics, but getting people to laugh isn't that hard. We were a bit concerned about people moving their arms up and down because, as you can see in the picture down the bottom left-hand side, people are doing a sort of a wave laughter therapy, and so we have laughter bands where we keep the vascular access stable. Similar, we thought we'd have problems with central lines, but that wasn't the case. Even though there's a change in intrathoracic pressure when you laugh, it doesn't affect the blood flow from a central line. We need to educate, support and observe the laughter therapists. Not all laughter therapists actually are very good in dialysis clinics. Most of them are fine, but some of them just don't get it and don't realise that people on dialysis have a certain aspect of life that sometimes they don't want to be happy, jolly people, which is fine. And it's really important that the dialysis staff are involved in every step of the way, knowing what session times, the noise levels people do, and what exercises people might want. And it's okay that patients refuse. We found about 1 in 5 or 20% of people really don't want to have a bar of laughter and leave the headphones on. But most of these people will say, I don't want to be involved, but I love it, the fact that Mr. Smith next to me is laughing, and so that's great. So what's the future? Well, people can try this out themselves. Like I said, there are some sheets that we have and some information sheets and certainly some research that goes on. But we'd really like to see more of this or interventions like laughter. We could potentially use these to improve the patient experience. Potentially we have it as a marketing thing where people might want to go to a laughter therapy dialysis clinic. I'd love to have a chief happiness officer wherever I worked. And we're also, we've worked on laughter sessions. So online you can find HD laughter therapy exercises where the laughter therapists have done how to do laughter therapy on dialysis. And these can go on the monitors that surround most dialysis units, or people can look at them from the tablets. And down the bottom, if you'd like to know more about those, we've done a few publications that you could potentially look up to find out more about this. Thank you very much.
Great, thank you, Paul. So again, we'll open it up for questions. You can via the chat or just take yourself off mute if you'd like.
I want a demo.
Look, you can do it online, but I'm not a laughter therapist, and I'm not. So I could be dangerous. It's just like anything else. If you can do it, you can do it well. If you don't do it well, sometimes that's contraindicated to a good intervention. So as much as I love being involved in it, and I can tell you that if you do a half an hour laughter therapy session, you're exhausted. And I've done quite a few, and I'm exhausted. So patients do get a proper good workout because they're laughing, they're using their chest muscles, they're using their arm muscles, and they can also do bike riding laughter as well, so they can use their legs. So it's hard, and it's 6:30 in the morning here, Stephanie, so it's really hard to do a laughter session.
Well, it's Nancy. I happen to be a laughter leader. We could do a really simple exercise. Do we want to try?
Go for it, Nancy.
Okay, this is great. So what you're going to do is take a deep breath in, put your hands over your head, tickle the sty, and go hee 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 hee. And then you're going to take another deep breath in, let it out with a sigh. And that's your sample. There's lots more.
Great. Thank you, Nancy.
Welcome.
Thank you.
All right, we got a question from Heitor. What professionals from the dialysis staff currently prescribe or supervise your laughter therapy?
Yeah, sure. So what we try to do is there's usually, like I said, a person, it's often the centre manager or the charge nurse who ensures that it's okay and it'll work. As most of us know, we don't see nephrologists a lot in dialysis clinics, so they're happy for usually to go ahead. And generally we do, and I didn't mention this, that we do laughter sessions with the staff beforehand, which is quite an important thing. So they actually know what you've just been through, except they do a proper laughter therapy session. So they know what it feels like and they can encourage that. So it's really important for, yes, to get management's okay. We can't do this without it, but also the staff that are on board, and most dialysis units have senior people who make the rules, the unwritten rules. And if they're involved, then a lot of people go along. But pretty much whether you're a technician, a nurse, a dietitian, we've got dietitians and we've got social workers who are also highly involved in the laughter therapy sessions. So although there is some sort of governance, they're really, the laughter therapists are pretty much understanding of what we can do and what we can't do. And I think that's really important.
Great, thank you, Paul. So we'll keep things moving along and we'll move to the next presenter. Thank you.
Thank you, Paul. Our next presenter is Nico Chavez. Nico is a doctoral student working under Dr. Danielle Kirkman in the Cardiorenal Physiology Laboratory at Virginia Commonwealth University. His research interests are focused on the effects of exercise on vascular health and its downstream effects across the spectrum of CKD.
Awesome. All right, thank you for the introduction. I hope everyone's having a great afternoon on World Kidney Day, and we'll go ahead and get started. So in general, this is about wellness interventions in chronic kidney disease. And so I just kind of want to touch on some of the things that we see with chronic kidney disease. Even in the early stages, and as we progress through CKD, we see a decrease in both physical function and exercise capacity. And with these decreases in physical function and exercise capacity, we see these patients adopt more of a sedentary lifestyle. And this can result in a reduced quality of life and the reduced ability to complete activities of daily living, which some people have already touched on, especially without assistance. A sedentary lifestyle also contributes to an increased burden of some of the comorbidities that go along with CKD, such as diabetes, hypertension, and cardiovascular disease. A sedentary lifestyle also predicts the chances of survival within this group. And for some of the patients who have CKD and are approaching end-stage renal disease, who may require some sort of renal replacement therapy, such as hemodialysis or kidney transplantation, they actually have a worsened prognosis if they're frail before starting these therapies, which is associated with a sedentary lifestyle. So as I say this, we're probably all very well aware of the fact that exercise is recommended for patients across the spectrum of kidney diseases in order to combat some of these detriments that we see with the disease. And exercise is recommended for these patients on most, if not all, days of the week. Despite the fact that this is the recommendation, exercise still isn't implemented as part of routine care in many clinics across the country. Specifically, we're here in the United States. As far as all of the reasons for the lack of exercise being implemented, not everything has been completely characterized, but some of the different reasons for the lack of exercise interventions are the lack of time, and maybe the lack of knowledge of physicians as far as exercise prescription is concerned in order to properly counsel these patients in order to implement exercise into their standard of care routine. Also, here in Richmond, Virginia, where VCU is at, even if patients with CKD did want to adopt an exercise program, there isn't really anything available that specifically tailors exercise prescription to patients with CKD targeting the disease, especially across the entire spectrum. So here at VCU, we've started to introduce and implement a program that we like to call Renal Rehab. And this is a completely free of charge intervention that we offer for patients across the spectrum of kidney diseases that includes a comprehensive, multidisciplinary, patient-centered approach to wellness. Now, this is one of the few programs in the entire country that offers this sort of intervention. And it's unique in the fact that we don't just exercise training, but we also implement nutrition counseling and lifestyle behavior change counseling as part of the intervention. And the goal is to bring awareness to this type of intervention and hopefully press forward for this holistic intervention to be adopted as routine clinical practice in clinics across the country. This program also enables us here at VCU to conduct some research that contributes to the literature as far as the effects of exercise and furthermore, the effects of this holistic program on patient outcomes and quality of life across the spectrum of kidney diseases. It also allows us the opportunity for teachers, healthcare professionals, students, all of us here to start collaborating and building a community focused on patient outcomes and completely patient-centered. So as I mentioned, the three aspects that we mainly focus on are exercise training, nutrition counseling, and lifestyle behavior change counseling. So I'll just kind of dive a little deeper into each of those. So as far as exercise training, we offer a 3-month supervised exercise intervention that, again, patients are referred by their clinician and is completely free of charge. We have a team of exercise physiologists that individually tailor the exercise prescription to each patient based on their medical conditions, where they fall on the spectrum of kidney diseases and on their personal goals. Also, each exercise session is supervised by an exercise physiologist, and they have a one-on-one exercise training session and education from our physiologists. We also conduct routine health, physical function, and quality of life follow-ups to track their progress throughout this program. And our exercise physiologists, as far as education is concerned, we try to interact with these patients and let them know when to exercise and when not to exercise, because the goal is to allow these patients to continue an exercise program outside of a supervised setting after the 3 months of supervised exercise training. And so we monitor blood glucose, blood pressures, contraindications to exercising, and we just make sure that patients are aware of these things so that when they do leave our intervention space, they have the information to continue this type of training. As far as nutrition counseling is concerned, we also have a panel of expert nutritionists who come and do a comprehensive dietary recall one-on-one with our patients. And after this, they provide individualized nutrition education, again, based on the patient's medical condition, again, where they lie on that spectrum of kidney disease and their personal goals. Again, everything is one-on-one, patient-centered, interactive between the patient and the expert. And again, we track progress throughout the length of this intervention. The last thing I want to mention is our lifestyle behavior change counseling as part of this program. So we do have a behavioral change specialist that comes and conducts a comprehensive patient-centered goal-setting activity with our patients, and that provides us insight on how to manipulate certain aspects of our program specific to the patient to help them achieve their health outcomes and their personal goals. We also identify different barriers to lifestyle change and implement strategies on how to address those barriers and how to, again, promote exercise and healthy living into these patients' lifestyles. Again, everything is one-on-one counseling with our expert behavior change specialists. And the last thing I want to touch on again is that the goal of this program is to help these patients transition to independence, moving from a supervised exercise program to a home-based physical activity and exercise program in which they have the information and the tools in order to continue this type of behavior even after our supervised 3-month intervention. We also encourage patients after this 3-month intervention to routinely come back and check in with us every 3 months up to the year mark in order to do some health, physical function, and quality of life follow-ups in order to track that progress, in order to answer any questions that they may have while they're on their own. And the last thing I have here is just team strategy and results. One of the biggest things that I think this program brings is the opportunity for healthcare professionals, nutritionists, exercise physiologists, students, clinicians, in order to build this team, in order to reach out to the community, in order to serve the community and focus specifically on the patients, to help bring awareness to interventions that can help these patients and improve quality of life. By using this strategy of a more comprehensive, holistic approach, not only utilizing exercise training, but also nutrition counseling and lifestyle behavior change counseling, can lead us to the results that we're looking for as far as an improvement in patient outcome, improvement in patient quality of life, and ultimately implementing this type of approach across clinics throughout the country and even throughout the world. Thank you.
Great, thank you, Nico. That was great. Again, we'll open it up for questions. Heitor has a question. What institution is responsible for sponsoring the program?
So this program is ran completely through Virginia Commonwealth University here in Richmond, Virginia.
Actually, I have a question. You spoke obviously a lot about the individuals at the university kind of dictating and controlling the program. Is there any, or if you could speak of any, help from the clinic itself as far as the techs, the dietitians, nurses, or physicians? And if so, do they kind of advocate, or are they helpful at all? How's that kind of interaction?
Yeah, so as I mentioned, we do keep in contact with the clinicians throughout the intervention. As far as being referred to the program itself, these clinicians obviously are advocating for the program because they are referring their patients to come and exercise with us. As far as keeping in communication, we do know that there are many benefits to exercise. So keeping in constant communication with those clinicians, with those nurses, if we do need to adjust different medications, for example, a blood pressure medication, with chronic exercise, we see decreases in blood pressure. Keeping that line of communication open is critical. So yeah, as I mentioned, this is definitely something that requires the contribution of the entire team in order to focus on the patients and provide the best outcomes as far as the intervention.
Great, thank you. So Heitor actually has a clarification. How long will it last? So how long will that connection with the clinics in this program through VCU?
So we actually just started this program, and we have some referrals already that we've began to work with. The intervention itself will provide the supervised exercise training program for 3 months. And again, as I mentioned, we'll keep follow-up for up to a year after that in 3-month intervals. Again, we are expecting our referrals to drastically increase within the next few months. So the hope is that this would last long-term.
Great, thank you. And one last question here from Naomi. What do you think are the biggest barriers of home-based exercise? Or are you expecting any barriers to come up with patients transition from the supervised exercise to more of a home-based exercise?
Yeah, so there's a couple questions there. First of all, as far as barriers to exercise outside of the clinic, the lack of education that we typically see as far as exercise is concerned is always a concern. But as I mentioned, we provide some insight into some of the things to look for that these patients can be aware of once they make that transition. What was the other part of that question? If you don't mind.
So just the barriers from home exercise to transitioning to, or from supervised to home-based.
Okay, yeah. So, and that's another thing that I think is really unique about this program. When you're involved with this well-qualified team of individuals that are encouraging and motivating you all the time within the clinic, that provides a sort of encouragement and motivation that might be able to push you a little further than what you would think. When you leave the clinic and you are on your own, the requirement of motivation kind of falls more on you. So that might be a barrier. Again, we just started this program, so we haven't actually pushed patients all the way through the program in order to be on their own yet. So those are definitely some things that we'll keep in mind as we keep this program running, and we start to see some patients finish the program.
Great, thank you, Nico. I know there's another question in the chat, but we got to keep things moving. So actually, Nico, if you could answer that in the chat, that'd be great.
All right.
We'll move to the next presenter. Thank you.
Yeah, thank you, guys.
Thank you, Nico. So our next presenter is Dr. Courtney Lightfoot, and she is a mixed methods researcher working with the Leicester Kidney Lifestyle Team at the University of Leicester. She has an interest in developing, evaluating, and implementing complex health interventions, self-management of chronic diseases, health and lifestyle behavioral change, and patient experiences of living with a chronic condition. Courtney is currently leading on the development of an online self-management intervention for people with kidney disease.
Sorry, I couldn't find my own mute button then. So today I just wanted to talk about a intervention that we've been developing in Leicester. So this is an online self-management intervention that incorporates education about how to live well with kidney disease and to support individuals to self-manage and engage in health-promoting behaviours. So this is called My Kidneys and Me. So I'm just going to kind of give you a bit of an overview about what it looks like. So this is kind of what the homepage looks like. And as you can see, there's learning sessions that range from basic information such as what the kidneys are, what the kidneys do, to kidney disease, and then much more holistic things such as diet, exercise, symptom management, and looking after well-being. So in terms of the learning sessions, and this is kind of what one of the learning sessions looks like. So this is the keeping the muscles healthy. So as you can see, there's things about what the muscles are, why muscles are important for the health, how you can improve your muscle health, what strength training is. And then to support these, there are what we call booster sessions. So these are how-to sessions. So these are the behaviour change sessions that provide the information and strategies and tips to help patients do the necessary thing that's attached to the education session. So for example, in the strength training one, there's like, how do I start strength training? How do I monitor and track my exercise? And how do I progress my strength training? In terms of this, we've also got resources to support this. So these are our strength training resources that are available. So there's hints and tips about strength training. There's do it with me sessions where patients can follow videos and do the exercises along with the videos. And there's also flashcards available about each of the individual exercises and videos that go alongside those. And there's also activity trackers, so people can track their physical activity. So this is kind of what it looks like. There are also health trackers where people can track different components of their health. And there's also goal setting features that people can choose. There's already pre-populated ones, but then people can also make their own goals. And so this is kind of a bit more what the decision maker looks like. It is into individual pages, but I've kind of just put them all together so that you can see what it looks like. So obviously there's how important is this change to me? How do you plan or aim to achieve this? What barriers might be preventing you from achieving this? How you might overcome this? How confident you are in making the change? And who you think you could support to help you make and achieve that goal. There's also a chat feature, so that's the top bit, so people can chat or patients can chat amongst themselves and provide different support. So there's obviously different aspects to it. So there's the general chat, and then there's exercise, diet and health. There's also a Ask the Expert feature where patients can contact us asking various questions that they may have, and we can respond to that. So as part of this, this is going to go into a clinical trial, which is a randomised control trial with a nested pilot, and it has a 2-to-1 randomisation to the intervention. So as part of this, we'll be testing My Kidneys and Me, which is the intervention. So it's a 10-week intervention with a 10-week follow-up with 3 questionnaires available at different time points. And following the intervention or following their participation in the study, patients can have access to the programme for up to 2 years. And as part of the study, there's also a sub-study, and in this, we're going to be assessing the muscle and physical function of patients. And also there's going to be a qualitative component where we interview patients about their experience and their engagement with the programme. And as part of the nested pilot, we're going to use the first 60 participants of the trial, and we're going to assess the feasibility outcomes of it. And then in terms of the whole trial, so the randomised control trial, our target sample size is 432 participants, and our primary outcome is patient activation. And then here's just a breakdown of the topics that are covered across the intervention. So I can take any questions.
Great, thank you, Courtney. That was wonderful. Looks like a great app there. That's awesome. One quick question. Yeah. So I'll open up the questions. I have a quick question. How long did it take to develop that app?
A very long time. So it's been in development for the past year or 2. So it's almost there. We're just in the final stages at the moment. So hopefully the trial is going to start in April, or that's the plan. So yeah, so it's nice to kind of see the end of it. It'll be good to see how patients interact with it.
Yes, that's wonderful. So if there's any other questions.
I have a question. I was just wondering, it's excellent job, Courtney. It looks amazing. Is that something we can eventually connect to the GREX website as a resource for everyone around the world?
Hopefully.
The ultimate goal, right?
Yeah, long-term goal.
It looks amazing. Well done.
Thank you.
One question through the chat via Nancy. Is there any support for energy management or coping skills?
Yeah, so as part of the symptoms, so there's an educational session about symptoms, and in that we cover the most common symptoms that patients experience. And then in the how-to session or the booster session, there's strategies to help manage those symptoms and how to monitor those symptoms. There's also a symptom tracker in the intervention to be able to help people track their symptoms across time, so that they can then use it to go to healthcare appointments and, you know, show their doctor, like, this is what I've been feeling and this is how this symptom has been going for however long they've been tracking it for, and they can see trends over time.
Great, that's excellent. Any other questions? I think not, so thank you so much, Courtney, appreciate it.
Thank you.
We'll move to the next presenter.
Thank you, Courtney. Our next presenter is Heitor Ribeiro, who holds a BSc of Physical Education and Sport, as well as an MSc in Exercise Science from the Catholic University of Brasília. Currently, he is a PhD student at the University of Brasília, Faculty of Exercise Science. His research interests include intradialytic exercise programs and the association between sarcopenia and osteoporosis in CKD.
Thank you very much, Oksana, for your introduction. I'm more than happy to be speaking with you at the World Kidney Day, held by GREX. And I'd like to discuss about some wellness intervention we've been promoting to our hemodialysis patients here in Brazil, which is entitled Integrating Undergraduate Exercise Students to Promote a More Active Lifestyle into Hemodialysis Patients. So you might be thinking, why am I going to talk about exercise students and not specifically about hemodialysis patients? But first, I'd like to give some comments about the Brazilian perspective on it. So who are the exercise students in Brazil? So here in Brazil, different from many countries, exercise science and related areas are destinated only to 2 courses, undergraduate courses. Here in Brazil, for example, a nephrologist, a nurse, a dietitian is not able to prescribe and supervise exercise. And if she does, she would be out of law and could go to jail. Yeah. So here in Brazil, we have only 2 professions who are able to supervise and prescribe exercise, which is exercise physiology and physiotherapy. And these 2 subjects, they study the basic area of health and also specific areas like kinesiology, biomechanics, and clinical exercise physiologists, and many other rehabilitation areas such as pulmonary, cardiovascular, musculoskeletal. However, most of them, of these exercise students and undergraduate courses, they do not study nephrology rehabilitation. So we only have these 2 professionals who are legally able to prescribe and supervise exercise to hemodialysis patients and all of the patients, and they currently do not study nephrology rehabilitation. So it's a scenario really, really sad. And we are trying to do something different to promote to these exercise students some information about nephrology rehabilitation that may, in the future, when they graduate themselves work with chronic kidney disease patients. So we have implemented a nephrology rehabilitation subject in our university a year ago. During this period, we had more than 50 physiotherapy and more than 10 exercise physiology students involved. By now, it's not an obligatory subject. The students, they decide or not to study this subject, but we are happy about the results, especially because we are getting more exercise students involved and interested about nephrology rehabilitation, which it gives us, the second important question. Why is that important to get hemodialysis patients more active? You might be thinking this, and I have some answers, maybe some perspectives about it that we are trying to answer here with our experience. Well, if we integrate the exercise students to the nephrology rehabilitation world and area, when they get graduated, we'll have more exercise professionals interested in nephrology rehabilitation. For example, here at the clinics, we have partnerships when we need to hire an exercise physiologist or physiotherapy to work at the dialysis clinics. Most of the time, we cannot find someone who is specialized or even know about nephrology and hemodialysis. So we really believe that introducing them to this work and rehabilitation area will give in the future more professionals involved in nephrology rehabilitation. Also, we are being able to provide to our exercise students some nephrology rehabilitation internships. In the dialysis clinics, we have partnerships, and it's something really interesting because it's free of charge to the patients, to the clinic, and to the university. So most of the students